Well, whatever patient is in your care, whether it's in a medical ward, a surgical ward, elderly care ward, operating theatres, intensive care unit, it doesn't matter. Wherever you're working, you're going to have to consider your patient's water balance. How much water is going in, how much water is coming out, how much water is there in the body at the moment. So in all patients, we need to assess their ability to drink. For example, if patients have had strokes, they might not be able to drink. If patients have low levels of consciousness, then they won't be able to swallow. So we need to assess every patient to make sure that they're able to drink normally. If not, we're going to have to work out how we are going to get the required amounts of fluid into that particular patient. And a lot of the time we can keep fluid balance charts. So if there's any question to doubt the amount of fluid going in or the amount of fluid going out, or if that patient has some disease state that could affect fluid balance, then that patient should be on a fluid balance chart. And this means we record all the fluids that go into the patient, and we record all of the fluids that go out of the patient, and we balance these to see if they're in a negative balance or a positive balance. If they're in a positive balance, it means they're going to be accumulating fluid. If they're in a negative balance, it means they're going to be progressively losing fluid. So what is their water balance? We need to do a fluid balance chart. And we need to account for what is called insensible loss. Now, if the patient vomits or has diarrhea, or if the patient passes urine, then we can see that the fluid is overt coming out. We can measure it and calculate how much water the patient is losing over a 24-hour period. And even if the patient's sweating a lot, we can actually see the sweat, and we can take that into account because we can see it. We can work out how much, we can't really work it out, but we can decide if the patient's losing a lot of fluid through sweat or if they're not losing a lot of fluid through sweat. But the insensible loss, we can't actually see it. It's insensible. So how much fluid is lost by patients through insensible loss? Well, the skin actually leaks. Fluid will leak out through the surface of the skin at the rate of about 400 or 500 mils per day. It's called transpiration. The skin is not completely waterproof and some water will be lost. And you all know that if you breathe onto a glass, it mists up because you're breathing out water vapour with your breath. So in an unstressed patient, just lying around in one of our hospital beds, not doing too much, again, we could expect them to lose about 400 mils a day through expiratory fluid losses. So that's 400 or 500 mils a day through the skin, about 400 mils that the patient's breathing out. So patients are losing about 800-900 mils a day through insensible loss. But of course there's also some insensible gain, and this is called metabolic water. So as a result of processing foods, patients can gain about 400 mils of water a day. So what we normally say in hospitals is that insensible loss is about 500 mils a day. For example, if a patient's in acute renal failure, we normally say that the patient can have the fluid that they lost on the previous day plus 500 mils on insensible loss. So for an unstressed patient, we normally calculate it at 500 mils a day. But if the patient's stressed, that could go up, or if it's hot weather, that could go up, or if the patient's got a fever, that could go up. So we need to account for it, and we need to use judgment really. But the tradition is to say 500 mils a day. And the other thing we can do, of course, is daily weights on our patients. Now, a litre of water is going to weigh 1 kilogram. So if a patient's losing or gaining weight quickly, that's almost certainly going to be because they're losing or accumulating water. So daily weights are sometimes useful, especially in patients with renal diseases. Now let's think first of all about what happens if a patient's getting too much water. Well, there can be too much water in the body if there's increased intake or reduced output of water. And a common cause of this is iatrogenic fluid overload. This is if we give too much fluids intravenously. It's very easy to give fluids intravenously, and it's quite easy to give patients too much because they just run in nice and quickly, and the patient can end up with too much fluid. That can cause iatrogenic fluid overload. And this is particularly a risk in children, because obviously children have got way lower blood volumes than adults. So if we give children a litre of fluid, that can be a huge amount of fluid for a child. In fact, that can be a life-threatening amount of fluid. Well, certainly it can. I mean, when you're 6 months old, you've only got something like 500 mils of blood. So that's related to maybe 5 litres or 5.5 litres of blood in an average-sized adult. So for every mil of fluid you give a child, it's like giving an adult 10 mils of fluid. So we have to titrate fluids in children very carefully and take very stringent measures not to give them too much fluid. We normally use volumetric devices or burettes, so there's no possibility of inadvertently running in 500 mils or a litre of fluid while you're away having a cup of tea if the regulator on the intravenous giving set is left open for too long a period of time. In fact, it doesn't even have to be a long period of time because the fluid can go in really quickly, and make no mistake, that can kill children. Another cause of fluid overload I've seen is in psychiatric patients where they drink too much. This is called polydipsia. So there are a few things that can cause fluid overload, too much water in the body. But there's also disease states that can cause fluid retention. And the obvious one is renal failure, acute renal failure or chronic renal failure. The kidneys are no longer able to excrete water in the urine normally. So renal impairment can lead to fluid overload. And heart failure can as well. In patients with heart failure, the blood is not circulating through the heart normally. It's backlogging into the venous circulation, and it's causing edema and fluid buildup. And another one is hypoalbuminemia, or indeed any sort of hypoproteinemia, when there's low amounts of protein in the blood. In fact, the most common protein in the blood, of course, is albumin. It's albumin that gives blood its osmotic potential. So if there's a hypoalbuminemia, then there's not going to be enough osmotic pressure in the blood to suck the water back into the blood at the venous end of the capillaries. That means that the water that should be sucked back into the blood at the venous end of the capillaries is left in the tissues as edema, and that will build up. And liver failure is another cause of this. In hepatic cirrhosis, for example, one of the normal functions of the liver is to produce proteins, and if the liver's not working properly, there can be a hypoalbuminemia leading to edema. So that brings us nicely onto the clinical features of excess amounts of water in the body. Now, the clinical features really are going to depend on the health of the heart and the renal system. So if the kidneys are working properly and there's too much fluid in the body, then there's going to be polyuria. There's going to be large amounts of urine produced, and it's going to be very light coloured with a low specific gravity. But if for any reason the water is not being excreted, then we can expect to see edema, and particularly we can see pulmonary edema. Now, the first thing we might recognise in pulmonary edema is the patient starts to complain of orthopnea. Now, orthopnea is shortage of breath. The patient feels short of breath when they're lying down. Then when they sit up or stand up, they can breathe easier. The shortness of breath, the dyspnea, is reduced by sitting up or standing up. And the reason for this is that there is pulmonary edema, that is fluid in the lung fields. And when the patient's lying down, this fluid will go all over both lung fields and interfere with oxygen and gaseous exchange at the level of the alveoli. But then when you sit the patients up, the fluid's going to run to the bottom of the lungs. Now that still means there's too much fluid in the bottom of the lungs, but it does mean that the upper lung fields are clear and normal gaseous exchange can take place. So orthopnea is dyspnea. The patient feels short of breath when they're lying down, but then when they sit up they feel better, and that should alert us to the possibility that the patient has pulmonary edema. Now another clinical feature is raised jugular venous pressure and raised central venous pressure. You might be able to see the raised jugular venous pressure in the neck veins, and the raised central venous pressure we can measure if we're using invasive and sophisticated techniques. And heart failure, if it's present, will be made worse by fluid overload. It will exacerbate any heart failure which is already present. That's why if patients have any cardiac compromise or a myocardial infarction, we don't want to give them intravenous fluids because it can send them into heart failure. Sometimes, especially if there's liver failure, patients can get ascites, which is accumulation of fluid in the peritoneal cavities, and the tummy gets blown up with fluid. And also, if there's too much water in the body, that can dilute the electrolyte concentrations in the blood. So we can get spurious low levels of electrolytes in the blood. We can get spurious hyponatremia or spurious hypokalemia. Well, if there's too much water in the body, what are we going to do about it? Well, obviously we want to try and treat the underlying cause if we can. And we can also give diuretics. If the kidneys are working at all, diuretics are going to increase urine output, getting rid of this excess water. If the kidneys aren't working, then we can think about dialysis or hemofiltration. And of course, we can limit the amount of fluids that we give these patients. We can fluid restrict them until the fluid levels get back down to more homeostatic levels. So that was thinking about what happens when there's too much fluid, when there's a fluid overload in the body. But what about if there's not enough water in the body? We probably come across this more commonly actually when there's not enough water in the body. What can cause this? Well, obviously lack of water intake can cause it, or excessive loss of water can cause it. And we see this quite frequently in vomiting and diarrhea. Both vomiting and diarrhea can give rise to significant fluid losses. And in some cases of gastroenteritis, patients can become acutely dehydrated really quite quickly as a result of vomiting and diarrhea. And again, this is especially true in children simply because they have less mils of fluid in their body to lose. So vomiting and diarrhea can both be life-threatening conditions in children, and indeed tragically are a common cause of death in children around the world, simple vomiting and diarrhea. Burns are another cause of fluid loss because when the skin is damaged, when the integument is damaged, there's lots of inflammation and lots of fluid can be lost from the surface. Another cause of not enough water is excess sweating, as in hot environments or increased workloads. And fevers will also increase water loss and can lead to dehydration. And there's medical causes as well. For example, diabetes insipidus is caused by a lack of antidiuretic hormone and can lead to dehydration. Or there can be an osmotic diuresis when a patient is hyperglycemic. So if a patient's hyperglycemic, there's going to be glucose lost into the glomerular filtrate in the kidneys, and there's going to be an osmotic loss. The osmotic diuresis is caused because the glucose in the renal tubules is going to attract lots of water in. That's going to be retained in the tubules. That's going to be passed into the collecting ducts, and it's going to be lost in the urine. So patients who have diabetic ketoacidosis in type 1 diabetes we would expect to be dehydrated, or patients with hyperosmolar non-ketoacidosis in type 2 diabetes we would also expect to be dehydrated. So that's DKA and HONC. And also iatrogenic causes. Water can be lost through giving too many diuretics, and indeed patients can become dehydrated if they drink alcohol, because alcohol is a diuretic. So if a patient's not got enough water on board, if they're dehydrated, what clinical features might we expect to see? Well, if they're awake and conscious, they're certainly going to complain of thirst. When you lose about 1 to 1.5% of body water, patients become very thirsty, and this can become a very intense drive to take on water. And the patient's mouth can be dry. And as patients become dehydrated, they're going to become oligureic, and eventually they'll become anureic. And if they become severely oligureic or anureic, as well as producing low volumes of urine, then essentially no urine at all, they're going to become uremic because they're not going to be able to get rid of the urea with the flow of urine. And there'll be a reduced central venous pressure and a reduced jugular venous pressure. And to try and compensate, the heart rate will start to increase. There'll be a tachycardia. And there might be features of vasoconstriction, such as pallor, because there's vasoconstriction to try and maintain the blood pressure as the patient starts to become hypovolemic. The other thing we can notice in very dehydrated patients is that they can suffer from postural hypotension. So when they sit up or stand up, they feel dizzy. And eventually this can give rise to frank hypotension all the time. But by the time someone's hypotensive with dehydration, it means they're already shocked. So that would be quite an advanced state of dehydration. But the patients won't feel well, they can be nauseated. In the elderly especially, we can see inelastic skin. The skin will just pucker up and bunch up when we squeeze it together. Although you can see that clinical feature in dehydrated children as well. And there can be shrunken eyes. The eyes appear shrunken. And if it's young children, there can be a shrunken fontanelle. And eventually there's going to be impaired organ function. The patient's going to become confused. And eventually they'll become comatose. And if we do blood tests, we'll see there's a hemoconcentration. Because there's not enough water in the blood, there's going to be an increased amount of sodium and an increased amount of potassium. But again, these are spurious effects because they're not really caused by an increased amount of sodium or potassium. It's just because there's less water to dissolve it in, so it's going to be a spurious hypernatremia, which is too much sodium, or hyperkalemia, which is too much potassium. Well, let's think about how we treat patients with diarrhea and vomiting. Well, it's important to realise that patients with diarrhea and vomiting lose water and electrolytes. They lose sodium and potassium as well as water. And we can treat them with oral rehydration salts. Now, oral rehydration salts are just drinks we give the patients. It contains water, it contains normally glucose or some sugar, some sodium and some potassium, because we're trying to replace the electrolytes. And the big thing about oral rehydration salts is that the glucose in the oral rehydration solution that we give the patient to drink is actively absorbed into the cells of the duodenum by active transport. That means you have a situation where you have a lot of glucose in the cells of the duodenum and water in the lumen of the duodenum. So that osmotically attracts water from the lumen into the cells of the duodenum, from the mucosal cells lining the wall of the duodenum. It's a very short distance into the capillaries in the submucosa. So what this means is if you give water on its own, it will be absorbed relatively slowly. But if you give water and glucose, it will be absorbed much more quickly. So giving these patients sweet drinks is good. And also if there's sodium and potassium in there, that will replace the lost electrolytes. So this is the standard life-saving treatment for children, especially with severe vomiting and diarrhea. And we need to give it regularly, because the trouble is when you give the patients, especially children, when you give them these drinks, they tend to vomit some up again. So we have to keep giving them it regularly, just with a spoon. And because it's absorbed quickly, hopefully we'll get more in than comes out again. But of course, if it's bad enough, they're going to need intravenous rehydration therapy. Now, if patients can't drink effectively, we can consider using nasogastric tubes and putting drips down nasogastric tubes, which is another good way to replace fluids. But obviously, if these measures aren't working properly, we can go on and give intravenous fluids as well. Actually, sometimes we can give subcutaneous infusions. This is called hypodermoclysis. We can just put a butterfly in and run in some fluids into the tissues. Now, you don't get a lot absorbed this way, maybe 60 mils an hour. But there again, you could have it running through 2 sites, which will give the patient 120 mils an hour. Well, you can run it through 4 sites if you want, it doesn't matter. So you can consider subcutaneous infusions. These are very useful if there's no one who's skilled at siting IVs. We can just start some subcutaneous infusions going, and at least it means the patient's getting some fluids. But intravenous rehydration is the definitive treatment in more severe cases. So, for example, after hemorrhage, we might want to give someone quite large volumes of crystalloid fluids. In fact, there's a saying, isn't there? For every big bleed, 3, 4, 1 you will need. So if a patient's lost a litre of blood, we need to be thinking about giving them 3 litres of crystalloid fluid replacement. And it's the same in burns. They're going to need a lot of crystalloid fluids for the first 24 hours. And then after that, we can think about giving some colloids as well. And with burns, we might want to use the Parkland formula to determine how much fluids that we're going to give them. So the principle of treatment in dehydration is very simple. Put the water back in. But with diarrhea and vomiting, as well as losing water, they're likely to have lost electrolytes, that is the sodium and the potassium, and they're also going to need replaced with oral rehydration salts or intravenous fluids. So when a patient's had diarrhea or vomiting, we must think about the electrolytes, the sodium and potassium, as well as the water.